So, with apologies to anyone who was at the Diabetes Initiative meeting, a lot of this is going to be replicative of that. So if you were there, perfectly okay for you to get up and leave. But I am going to try and put a slightly different emphasis on it in terms of the importance of connections. So I want to tell this story about diabetic retinopathy and some recent developments that I think we all should be aware of, and to try to figure out what the issues regarding connections are. And let me see. So I have no conflicts of interest. So the themes here relating to connections are: how do we figure out how to connect and translate new research knowledge into clinical practice? This is a huge problem. We have lots of knowledge, we fail to apply it. And it takes often years and decades to get clinicians to change their practice, even in the face of convincing evidence that they should do so. How do we connect different disciplines together? This is going to be an example to some extent of the gulf between different medical specialties like endocrinologists, diabetes docs, eye doctors, doctors who are interested in lipids. They need to talk to each other. They need to go to each other's meetings. They need to communicate and connect. How to connect past knowledge, things that are out there in the literature and may have been there for decades that everybody's forgotten about, that may be important. And how to connect different disciplines together so that a person reading a journal on this subject, how do they know that there's a journal over here on this subject, which might be astrophysics, that has something relevant to what they do, but they never look there. And lastly is kind of a repeat of number one, how to connect healthcare providers so that they can change their long-established habits. So this is a story about diabetic eye disease, and specifically diabetic retinopathy. You probably know that in the eye, diabetes causes cataracts, diabetes causes glaucoma, diabetes can cause hemorrhages in the eye, but diabetes damages the retina, the light-sensitive tissue at the back of the eye. And that is one of the commonest causes of adult onset blindness in the developed world. I want to overview what are current preventive measures, which are fairly basic risk factor management and current treatments, and then talk about something that's been realized recently that actually was to a large extent realized in the 1960s, but was completely forgotten. So what is diabetic retinopathy? Damage caused by diabetes to the retina, the light-sensitive film at the back of the eye. So there's the retina. It's an amazing piece of tissue, absolutely and totally unique. It has to last us all our lives. It's 1/10 of a millimeter thick. It covers the whole of the back of the eye. It's got dozens of different cell types which are highly specialized and which are unique to the retina. So how do we preserve it? How do we preserve this piece of electronic complexity, if you like, throughout the whole of our lives? And part of the answer is that it's actually more or less hermetically sealed. The circulation on the inside of the retina, shown there at the top, the inner blood-retinal barrier, on the outside of the retina at the bottom, the blood flowing through those is completely sealed off from the retina, and everything that goes from the blood into the retina is tightly controlled through these monolayers, single layer of cells, one cell thick. And, you know, the problem is if that one cell thick seal starts to fail, then you have a problem. It's like the outer part of a ship's hull failing, maybe a thin piece of wood or a thin piece of steel, but once it fails, the consequences are catastrophic. So we rely on these single layers of cells. And if you look at the complications of diabetes, and especially the microvascular, small blood vessels in the eyes, the kidneys, and the nerves, every time there's a single layer of cells that provides a seal that protects the specialized tissue from the outside world, the outside environment of the patient. Diabetes has the propensity to damage those monolayers. It may be because of fluctuating glucose levels, it may be of intermittent acidosis, it may be of metabolic effects inside those cells, because unfortunately, those cells, those epithelial or endothelial cells, they don't need insulin for glucose to go in. Lots of important parts of the body do, like muscle and fat, liver and so on, to respond to insulin. But these specialized endothelial cells, they don't need insulin for glucose to go in. And that means when glucose rises in the blood, as it does, that glucose just flows straight into these cells and causes metabolic abnormalities that can contribute to these specialized barriers that break down. And I didn't mention the placenta. We're very interested in diabetic pregnancy, but the placenta also has a monolayer of cells that isolates the baby from the mother's circulation. If that gets damaged, same deal. The gut, you know what's inside your gut right now after lunch? You don't want that getting into your bloodstream, do you? How thick is the layer of cells that prevents it from happening? 1 cell thick. And in diabetes, we get all kinds of liver disease, and that's because where does blood go after it's absorbed from the gut? It goes straight to the liver first. And so it's not surprising that we get inflammatory liver conditions in people with diabetes. I think these are important considerations that may explain why the places that get microvascular damage get that damage. Here's a normal retina on the left. See a beautiful structure, ordered blood vessels coming from the optic disc, the central retinal artery, the branches that you can see. That's the inner retinal circulation. We can see that when we look in the eye. We can't see the outer retinal circulation because it's behind the pigment epithelium, the black pigment layer that's like the black back of a camera back in the day. But both these circulations are prone to starting to leak in diabetes. And on the right is a picture of advanced diabetic retinopathy, and you can see here leaked out lipids that have gone into the retina and spreading out like ink on a blotting page, and hemorrhages, just widespread damage that diabetes can cause in the retina. And that means that you can't see properly, and this is just an image that's supposed to show what it's like to have severe diabetic retinopathy compared to normal vision. What are the risk factors for diabetic retinopathy? Well, we know a lot about this now, and this is not a great slide, but you can see at the top we've got A1C, which is not A1C itself, it's blood glucose. High glucose accelerates retinopathy. High blood pressure accelerates retinopathy. High lipids, to some extent, and this is a bit controversial, tend to accelerate retinopathy. And it's associated with changes that take place at times of hormonal change, like puberty, and related to our mom's program, pregnancy. If a woman gets pregnant, she's at risk of rapid progression of retinopathy. She needs a retinal examination early in the pregnancy and again late in the pregnancy. We've been trying to make that happen in the mom's program with some success, as you may have seen in the poster. Here's some associations. You can see at the top, males and females are about equally affected. With regard to race, white people and black people in the second group there are approximately equally vulnerable. The next is type 1 versus type 2 diabetes, and people with type 1 diabetes are more vulnerable than those with type 2. Diabetes duration, not surprisingly, the longer you've had it, the greater the risk of retinopathy. That's not something we can change. A1C is something we can change, and there's a strong association between A1C levels and risk for retinopathy. And then we have beneath that blood pressure, important, lipids, and well, when the work was done, it's getting better after the year 2000. So more background, a lot of people, 230 million people affected by diabetes worldwide. In 2007, at that time, it was predicted it would get to 350 million by 2025. Actually, the estimate today, 6 weeks from 2025, is 800 million people planet-wide affected now. And among these people, the risk of blindness is increased 25-fold above non-diabetic people. And you can see these serious consequences for the eye. There's various stages of retinopathy, and this is only up there because you can see you go as high blood sugar develops, you go through mild, moderate, and severe diabetic retinopathy over the passage of time. And early detection and correction of diabetic retinopathy is the best protection. But the question is, what can we do to prevent and, worse still, correct retinopathy? The answer is, it's a bit limited. for prevention, up until now, it's all been control of risk factors. Get good blood sugar control, get good blood pressure control. There are treatments for advanced sight-threatening disease with proliferative retinopathy. These are all things you don't want to have. Laser treatment, intraocular injections once every month or 6 weeks, or vitrectomy if things are really bad. You get the inside of the eye taken out so that you can see, because previously the hemorrhages had blocked it. So really, until now, there's been no specific targeted treatment that can block the progression of early to mid-stage diabetic retinopathy. This is the DCCT. Many of you will be familiar with this, and you know that this showed categorically, and I keep knocking the end off the microphone. I don't know what that end achieves, actually, but put it back. That intensive management of diabetes in youngish type 1 diabetic patients produced a dramatic, over a period of 6 years, produced a dramatic reduction in progression of diabetic retinopathy. Over on the left there for primary prevention, meaning the difference between no retinopathy and some retinopathy, was a 70% reduction. And on the right, secondary prevention from mild retinopathy to more severe retinopathy, also highly, highly significant. This showed for the first time that if you do good blood sugar control, you can prevent retinopathy. And the follow-up studies showed that you can also prevent the development of kidney disease and nerve damage and cardiovascular disease. And this study that began in 1984, still going on today, 95% of the surviving patients still participating. We have 60 or so of them at MUSC. And Harsha back there has been working with them lately, and we've all worked with them at MUSC over the years and decades. So what am I talking about? Well, I'm talking about a new role for an old drug, and here's the story. It began, you can see this 1969 paper. The work was done in Edinburgh and in London, and they were looking at fibrates because they thought that when retinopathy gets severe, you get a lot of fat deposited in the retina, and the hope was that maybe we could get rid of some of that fat with these drugs which reduce levels in the blood of triglycerides, and the hope was that if you could reduce the exudates, the fat in the retina, maybe there could be an improvement. And so this is what it showed, and if you look at this, you can, well, this is a little complex to say, but let's say it did show that this early fibrate drug, clofibrate, that was being used then, could reduce exudates, but more important, it could actually improve visual acuity. There was a small number of patients, it was significant, but it was too small a number of patients for people to get really excited about, and it never really got followed up. It just got neglected and forgotten. So today, the fibrate that we use, and this drug is used for lowering plasma triglycerides in people who've got hypertriglyceridemia, that's got nothing to do with retinopathy, is fenofibrate. It's not a new drug. It's been around since 1974. It has a well-known safety profile. It's safe and cheap, and it works. Its main recognized mechanism of action is lowering triglycerides, and you can see those effects on circulating lipids. And so it's one of the drugs that we use in people who've got severe familial hypertriglyceridemia. Now, many people thought, reasonably enough, that if you have diabetes and it's poorly controlled, you get high triglycerides and you get heart problems. So why don't, instead of using statins as the first-line drug, why aren't we using this? It lowers the triglycerides, which is what the most prominent thing that we see in a diabetic patient. So some studies were done, 2 major studies that I'll describe briefly were done to assess whether fenofibrate might be an effective drug for protecting diabetic patients against heart disease. And one of them was called the Fenofibrate Intervention and Event Lowering Study. It was done in Australia and Finland, and it had a primary endpoint of cardiovascular events, but there were secondary endpoints of microvascular complications. And in 2007, this finding was published about the effect of fenofibrate on the need for laser treatment. In other words, progression of diabetic retinopathy to a point where you had to have laser treatment. And this was a secondary endpoint of the study, and it showed, lo and behold, a reduction of about 30% in the need for laser treatment in 10,000 or so patients, half of whom got fenofibrate, the other half got placebo. And that's the placebo versus fenofibrate effect. So it was a major reduction. But again, because this was not a retinopathy study, this was a cardiovascular study, and because the cardiovascular outcomes were essentially negative, although some subsets did better, this was met with shrugged shoulders around the world. And that's just the other expression of the data. You can see if the boxes here are to the left of the vertical line, it means that there's a significant benefit from the drug, less of those events associated with fenofibrate treatment. The effect was broad-based. The study contained both type 1 and type 2 patients. It contained patients who got no retinopathy or some retinopathy at baseline. The effect appeared early, within 8 months of treatment. And most importantly, it appeared to have nothing to do with blood sugars, and more surprisingly perhaps, nothing to do with plasma lipids, which is what the drug is normally used for. It also showed that fenofibrate was beneficial across a wide range of degrees of severity of non-proliferative mid-range diabetic retinopathy. Then, a couple of years later, the ACCORD study was published, another cardiovascular risk study in which patients were put on fenofibrate. Same question, type 2 diabetic patients, fenofibrate. In this case, if they were already taking a statin, the fenofibrate was added to the statin. So this is basically statin or statin plus fenofibrate. And again, the primary endpoints were cardiovascular, secondary endpoints were microvascular, and this was the eye component of that study. And once again, you can see those fenofibrate data are to the left of the vertical line, indicating, again, significant benefits. And that those benefits were independent of race, they were independent of duration of diabetes, independent of age, independent of whether the patient smoked or not, independent of body weight, independent of glucose, and independent of whether retinopathy was present at baseline. So again, in this study, it was a 40% reduction in retinopathy progression in the patients getting fenofibrate as well as simvastatin compared to those getting simvastatin, a statin as well. So here we have two big cardiovascular studies showing the same thing, but in neither of them was designed to address the question of, is this drug helpful for diabetic retinopathy? So that's a summary of the two of them, and you can see they both agreed, and you do a meta-analysis combining the two, you got this significant reduction in retinopathy progression. And again, in both cases, it had nothing to do with what the drug did to plasma lipids. So just this year, presented at the ADA in June, was the Lyons study. And this study, unlike the other two, was a retinopathy study. It was a prospective study of fenofibrate versus placebo. And the question was, is this retinopathy effect true in a study that's designed expressly to find out the answer to that? And you all know the answer? You all know the answer? Well, I'll give you a bit of background first. So this was done in Scotland. It was a combination of the Scottish National Health Service and investigators at the University of Oxford. And they have this national diabetes eye screening program in Scotland. I wish we had one here, but we don't. And they screen the 340,000 patients who've got diabetes in Scotland on a regular basis for eye disease. And the study design was a randomized control study where the patients were prospectively randomized to placebo versus the test drug, fenofibrate. And there were about 1,000 patients in this study. The primary outcome was time of recurrence to referable diabetic retinopathy or maculopathy, which is damage to the middle of the retina, or specific treatment, like I mentioned, for either of those conditions. And there were a bunch of secondary outcomes which were related to other factors of visual function. And the 575 versus 576 patients were closely matched for age, sex. Both types of diabetes were included, equally distributed. And the retinopathy grades were similar between the two. And the past history of laser injections and vitrectomy were the same. And A1C was the same. That's not familiar units to us, but well, you can see it's 8.2%. Lipids were the same, and renal function was also the same. And then follow-up was at 4 years, and the vast majority of patients in both study arms were followed up. And basically, the results were like this. That was the placebo accrual of retinopathy endpoints, and here's the fenofibrate accrual. So it's very broadly similar to the two previous studies, but this one has retinopathy as a primary endpoint, and it was a 27% reduction in risk of progression of retinopathy. So here we have a cheap, safe drug, widely available, readily available, that has this 27% reduction effect on the progression of retinopathy, which acts independently of what the patient's blood sugar is doing and independently of what the patient's lipids are doing. So again, the same effect was observed in males and females, in people over the age of 60 and under the age of 60, in people with type 1 and with type 2 diabetes. And it was observed in people who had normal or abnormal kidney function, independent of A1C, and independent of the timing of the primary outcome. For those secondary outcomes I showed you briefly, again, all of them showed significant benefit mediated by fenofibrate. And so here it is added to the other prior cardiovascular trials. We see that these studies are largely in close agreement all the way down. And it seems to be really pretty convincing evidence. You may or may not agree. You can protest. But I think it's pretty convincing evidence that this drug really does protect people against retinopathy. So the summary, this is patients with early or mid-stage diabetic retinopathy or maculopathy. Fenofibrate reduced progression. The benefits were similar to those in various pre-specified groups of patients according to A1C or kidney function or sex or anything. It reduced any progression of retinopathy and macular edema. Benefits were similar to the cardiovascular studies, and the methodology showed that you can actually use large retinopathy screening programs like they have in Scotland, but like we don't have here. We couldn't have done this study here to find the answers to important questions. So the next question is, if this works, and it's nothing to do with what goes on with lipids, which is what we use the drug for up until now, then what is going on? And I want to wrap around again to that barrier function question that I started with. And you can think of diabetic retinopathy as a two-stage process, like a ship sailing in the ocean. The first stress is stressing the structure of the hull, but until the hull breaks down, things aren't too bad inside. But in the retina, it's the same thing. There are stresses outside. As long as they stay outside, it's okay. But if the barriers break down, then all hell breaks loose inside the retina. And so we have an initiation phase where plasma factors that stress the barriers are present but haven't yet broken the barriers, and a propagation phase once the barriers begin to break down. And once the barrier is broken down, then all the risk factors that mediate what's going to happen next differ, they change, because it then becomes really important what's in the blood, whereas before it wasn't so important what's in the blood because the insulation was there. So here's the Battle of Issus. Anybody heard of that? 333 BC, the Greeks versus the Persians, the Macedonians versus the Persians. And you see two lines of troops lined up, and you know what's going to happen next. The barrier is going to break down. So once those Persians have the Greeks through their lines and attacking them from behind as well as attacking them from in front, it's a totally different story. And that's what happens in the retina. I'm going to come to another piece of ancient history in a moment, but a significant breach in a line of defense is a catastrophe. The game changes, the risks become much greater. You have to fight a rearguard action with a much lesser chance of success. Strategy and tactics have to change. Important barriers must be defended. You've got to defend your line. And okay, here's a schema of a retinal capillary. The red things represent the cells that line the capillary, and they're supposed to be tight sealed so nothing can get through. In between the two red lines is the plasma. In the plasma is lipoproteins. Now, lipoproteins we recognize as driving atherosclerosis. When they get out of the artery into the wall of the artery, they get oxidized, they create inflammation, they create plaque, you get a heart attack. In the retina, they're not supposed to be out there at all. Once the barrier starts to leak, you have these, classical history, you have the lipoproteins stuck in the retinal tissue outside the blood vessels where they should absolutely not be. Once they get there, they get stuck, they get oxidized, and they kill every cell that comes near them. They're very, very toxic to cells. So it is just like the Trojan horse. The horse has got through the barrier, it's full of poison, the oxidized LDL, the LDL and the oxidized LDL gets in the retina, and the city falls, the retina falls. And that's a horribly inadequate picture of a very exciting slide of our own research. And I don't know if you can see, we need the lights down, but I don't suppose anyone can do that. These are actually human retinas from non-diabetic on the top left down to severe diabetic proliferative retinopathy on the bottom right. And there's a green stain there, I don't know if you can see it at all. It's the stain for oxidized LDL in the retina. And these are real human beings, cadaver tissues that we got. And in the non-diabetic eye, there is no oxidized LDL in the retina. And as retinopathy gets more severe, here's a diabetic patient who's got no clinical retinopathy, but there's oxidized LDL there. Non-proliferative, there's more. And here, you might be able to see down the bottom, there's a lot of green. Sorry, this is not easier to see. We did one more experiment that I'll bore you with, and maybe you can see these. These are, and we did, I'm sorry to say, we did cruel things to these mice. I mean, we do our best, but we feel that these are important issues that we've got to do. So this is a mouse that we've made diabetes with a drug called streptozotocin. You give the injection, the mouse becomes diabetic. And these are retinal sections from those mice. And what we've done here is that the time on the left side, 3 days, 7 days, and 14 days, is the duration of diabetes since the mouse was made diabetic. And across the top, what you see is saline, just salt water, normal lipoprotein, oxidized lipoprotein, injected into the eye so that it'll go into the retina. And the question is then, will it damage the retina? This is a model to try and look at the effects of that leakage of lipoproteins into the retina. And this is a normal mouse. It's not diabetic, and it's the control mouse. So it's 3 days, 7 days, 14 days after the counterpart mouse that has been given diabetes has had those injections. And what you see there is nothing happening. There's no difference between those sections. The oxidized lipids don't injure a normal retina. But if the mouse was diabetic before you put those things in there, this is what happens. You put in the normal LDL, the saline, and on the top left here, this is PBS, is saline, 3 days, 7 days, 14 days. The saline really isn't creating any trouble in the retina. The normal LDL, which is not oxidized, well, it's not doing a lot either, but there's maybe things beginning to show here. But when we put in the oxidized LDL, there's severe, rapid inflammatory damage of the retina. And then when we actually added fenofibrate into this equation, and so this is the diabetic versus the normal eye. The normal eye is on the left. Going down, you see fenofibrate in the diet, more fenofibrate in the diet, and fenofibrate injected into the retina. With a normal animal, nothing happens. But in the diabetic animal, when you put in the oxidized LDL and you have no fenofibrate at the top, you get a lot of damage. A little bit in the diet, you get less damage. High amount in the diet, less damage still. You put it into the retina, a tiny amount, before the animal is made diabetic and before you've applied any stimulus to trigger diabetic retinopathy, that tiny amount of fenofibrate inside the eye protected that retina completely from developing diabetic retinopathy. So this suggests that the action of fenofibrate is in the eye. It's not in the liver, or it's not in the plasma lipids. It's right there in the retina. And the question is, what might it be doing to the retina? And the answer is, of course, it might be protecting those barriers that we talked about at the beginning. So if you can strengthen the hull of the ship, and the ship is in severe weather and there's all kinds of damage coming at the hull, icebergs and so on, if you can strengthen that hull, you will survive. Fenofibrate appears to strengthen the blood retinal barrier and defend it even in the face of the stresses imposed by diabetes. So I don't know if you can see this, the diabetic animal at the bottom with the oxidized LDL going in. When there's no fenofibrate present, there's a lot of extra damage from the oxidized LDL, and that becomes insignificant as you increase the amount of fenofibrate, whether it's in the animal's diet or whether it's injected into the eye before the diabetes is even induced. Now, the field study went on to look at amputations and went on to look at kidney disease and neuropathy. And in all these cases, fenofibrate was associated with improved outcomes, as one might expect, if indeed, and I'm speculating, it protects the barriers of these cell monolayers generally throughout the body and prevents leakage into critically protected tissues that aren't able to defend themselves unless you strengthen the barrier. So this is a reduction of 36% in amputations in the field study in the patients getting fenofibrate. Here's a improvement in diabetic kidney disease, progression of diabetic kidney disease in the patients getting fenofibrate. And so I left these learning assessment questions in here. These are questions from this talk, as I say, was given at the Diabetes Initiative meeting. Which of those things are risk factors for diabetic retinopathy? Well, which one is not? Because one of those is not a risk factor for diabetic retinopathy, and all the rest are. Anyone want to answer? Not much difference in sex risk. It's slightly more in males than females, but not much. Any other bids? It's a surprising answer. Blood sugar control is a very strong risk factor for diabetic eye disease. Very, very strong, as shown by the DCCT. It's smoking. Smoking is not associated with an increased risk of diabetic eye disease. Yeah, smoking's not good for you, but it doesn't increase your risk of diabetic eye disease. Smoking. There's no evidence for smoking increasing retinopathy risk. Here's another one. In people with diabetes, the onset and progression of diabetic retinopathy can be delayed by 3 of those things. Do you think good blood pressure control delays it? Good blood sugar control? Good blood sugar control important? Yeah. Blood pressure control? Absolutely. Statins? Do statins improve diabetic retinopathy? Not really. And do GLP-1 agonists, these new wonder drugs and DPP-4 inhibitors, do they? Not definitely known, but no clear evidence that they do. Fenofibrate? Yes. True or false? For advanced sight-threatening retinopathy, anti-angiogenic injections are low cost and convenient. These are injections into your eyeball. They're neither low cost nor convenient. Laser treatment causes loss of retinal tissue and potential night blindness. True or false? True. It's a destructive treatment. Vitrectomy is a last resort for some. True. It's a sight-saving procedure if you've got a major bleed into the middle of the eye. Okay, true or false? In diabetic patients, pheno reduces progression of early retinopathy by 30%, independent of A1C, lipids, or type of diabetes. True. Reduces cardiovascular risks in some patient categories. It's true. It reduces cardiovascular risk in people with hypertriglyceridemia, severe hypertriglyceridemia. But it's not nearly as potent at doing so as are statins in general. May be combined safely with statin treatment. True. In the case of fenofibrate, it's true. May reduce progression of other microvascular complications other than retinopathy. Is true from the field study. Safe to use during pregnancy. It's category C. So it's not clearly safe or unsafe. May protect the blood-retinal barriers. True. And lastly, here's 3 people. Which of those patients would be the best candidate for pheno? 20-year-old woman, 5-year history of type 1, A1C is 6.8. She's got normal blood pressure. She has no evidence of any complications, and she's planning to become pregnant. Would you put her on fenofibrate? The answer is no, because she's planning to get pregnant, and there's always that question. It's not proven to be harmful. But on top of that, she's got no retinopathy at all, and the drug is really effective for people who've got some evidence of early retinopathy, more clearly than people who have none. Second one is a 35-year-old man with type 2 diabetes discovered 10 years ago. Remember, doesn't mean he's had it for 10 years. He's had it for at least 10 years, right? A1C is 7.9, blood pressure is borderline. Early non-proliferative retinopathy, microalbuminuria, mild blood pressure, mild hypertension on metformin, statin, HCG, and an ACE inhibitor. Pheno candidate? Yeah, clearly ideal pheno candidate. And the last one, 29-year-old with type 1 diabetes, but he's got laser treatment and severe impairment of his vision from diabetic retinopathy. He's really missed the boat for fenofibrate. He's not a fenofibrate candidate. However, he's got microalbuminuria, and if indeed it is effective for kidney disease and nerve damage and prevents amputations, and amputations are a big thing here in 29203, maybe we need to think about this. So the second guy is the one who's clearly there. Connections. Could the utility of fenofibrate in diabetic retinopathy have been realized earlier? The answer to that is absolutely yes, it could have been. Could have been realized 20, 30 years earlier if anyone had wakened up, seen those early results, and decided to do a definitive study. Did silos between disciplines prevent progress? I think the answer is yes. We have ophthalmology meetings and we have diabetes meetings, and never the two shall meet. We have obstetric meetings and diabetes meetings, same thing. People go to their meetings, they talk to their own silo, and they don't understand that something over there has happened that could change everything over here. These connections are critical if we're going to make, and the best example of this is A1C. So, you know the story of A1C? A1C was identified in the late 60s. It came into clinical use around 1980. But in 1912, all the chemistry had been sorted out. Was it in people with diabetes? Was it in human beings? No. It was in the food industry who were storing food in tin cans. And they worked out the chemistry of what glucose does to proteins. It was all known. And if you just thought, you could have made the connection and said, hey, if that's happening in a tin can, it can happen in a human body as well. And there's hemoglobin floating around in plasma, exposed to every fluctuation in glucose that happens. We could use that. It could have been discovered 30 years earlier. the DCCT could have been done in the 60s instead of the 80s. We could have known what we know about the importance of blood sugar control 20 or 25 years earlier if people had just made the connection between one discipline, food chemistry, and another discipline, the biochemistry of complications. So straight line thinking versus lateral thinking. This is a lipid drug. It must work by lowering lipids. Everybody thought that the effect of fenofibrate when it was identified back in the 60s was all got to do with lowering triglycerides, and that'll reduce those fatty exudates in the eye. It's got nothing to do with that. Got nothing to do with it. And will we implement this new knowledge at scale? Will we? We can't even give people statins, and we've known all about that for decades. We need to think about, are we going to take this information and give this cheap, safe drug to patients who meet the criteria for benefiting from it and reduce amputations and reduce progression of eye disease? Or are we just going to shrug our shoulders and say, well, we haven't been doing that, so why would we start now? So those are just the conclusions of the clinical trial again. So I think we're free for the prize draw. Any questions?